Hello everybody and welcome. My name is Tamsin Rose and I have the great pleasure to be the moderator for this hybrid session organised by Euractiv and EASL, the European Association for the Study of the Liver. And you're all here, I hope, because you are ready to discuss NCDs, obesity and liver health. And the question we're asking is, can the EU turn the tide? Let me introduce to you who's on our panel, and then I'll give some context to the conversation. Joining me in a little bit, coming hot foot straight from the European Parliament, will be MEP Tomislav Sokol, who is a member of the Santé Committee in the European Parliament. Next to me, I have Dr. Kremlin Wickramasinghe, who's the Regional Advisor for the WHO Euro in the Division of Prevention and Health Promotion. I have Dr. Andrea Ciudin-Mihai, who is an endocrinologist and obesity specialist and associate professor at the UAB, the Vall d'Hebron Hospital, and a member of the executive board of EASO, the European Association for the Study of Obesity. I have Cyrielle Cozy, professor of medicine and nutrition and endocrinologist diabetologist at Lyon First University and Hospices Civil de Lyon, and also from EASL, the European Association for the Study of the Liver. And also on the panel, I have Professor Dr. Gamal Shiha, Director of the European Liver Patients Association. So welcome to all of you. Let me just frame our conversation, and welcome to those of you who are joining us online. We will have a conversation. I will also be expecting to bring you into this, and you'll be coming in via Slido. So you need to go to slido.com and you need to put in the hashtag liverhealth, or you can hold up your smart device and look at the QR code, but that's where you will be sending in your questions to our panel. So it's slido.com and the hashtag is liverhealth, or you can use the QR code. So let me just explain why we're all here, just to make sure, just to put some facts and figures on the table. The EU's NCD initiative called Healthier Together runs until 2027, and it's got the aim of helping member states to reduce the burden of chronic diseases. And what we mean is the chronic diseases that are about 90% of deaths and 80% of years in poor health, so a significant proportion of the overall health challenges. And what we're talking about is the big four NCDs. That's cardiovascular disease, diabetes, cancers, and chronic respiratory diseases. 2/3 of the premature deaths from these big four come from tobacco and alcohol use, unhealthy diets, physical inactivity, hypertension, obesity, and environmental factors. And these are all risk factors that can be changed. They are amenable to policy interventions. And preventing or managing these risk factors is both a policy goal and incredibly challenging to achieve and deliver. So in this webinar, what we're going to do is we're going to shine a light on a lesser known aspect of NCDs, which is specifically the impact on the liver, or something called Steatotic Liver Disease, or SLD. And what that is a spectrum of liver disorders that are characterized by excess fat accumulation in the liver cells that can progress to inflammation, fibrosis, and cirrhosis. So it's something that is very hidden, because I don't know if any of you could put your hand on your body and point to where your liver is, but that's where the issue is dealt with. Just again, to get a sense of the size of the challenge, half of Europeans are overweight and 17% are obese, and these figures are trending upward. This level of metabolic dysfunction obviously has an impact on health, and it's estimated that SLD, the liver conditions, are estimated to affect about 4 in 10 adults worldwide, but often invisible in EU initiatives, including things like Healthier Together. So that's the context, that's why we're here. It's clearly a complex, difficult challenge to address, where there's both a policy goal and patients themselves want to get some change. I'm going to start by asking you all the same question. I'd like you to get your best pens out and give a mark out of 10 to current EU efforts to tackle NCDs, particularly obesity and related metabolic disorders. Marks out of 10 and why you've given that mark. So Kremlin, let me start with you. Please go ahead. Mike, that will work. Yes.
Dobro, nećemo mijenjati, ajde, dobro.
MEP Sokol is being mic'd up outside and it's already working. So yes, please go ahead.
Right. So I would give 6 out of 10. Why? I actually, he's coming in. Let him take a seat. Right.
Welcome.
Thank you. So yeah, I thought I would give 6 out of 10. First, when you asked the question, I thought I'm going to give 5 because in the EU, the WHO best buy implementation is 50%. So there are best buys, cost-effective policies. We know which policy should be implemented. We ask from each member state which ones we have implemented, and WHO publish a progress monitor that shows implementation is 50%. So for that, I thought 5 out of 10. But in the EU, we talk a lot about NCDs. For talking, I would give 1 more, so 5 plus 1, 6.
Okay, so great. We're giving the EU 7 out of 10 for talking and 6 out of 10 for delivery. You're being quite generous there. Some people might consider there's a bigger gap between talking and delivery. But okay, please go ahead, Andrea.
I will not be so generous. I wanted to give, I'm speaking from obesity perspective because I'm the obesity representative here. So just because it's holiday in December spirit, I would give 4 in obesity. And I'll explain you why. Because there's still a lot of misunderstanding on what obesity is. We keep putting everybody in the same bag. We keep thinking that people with obesity have to eat less and move more. And this is about willpower, and this is not. There are many types of diseases, and we keep mixing prevention with treatment. One thing is prevention, and one thing is treatment. Now we have a lot of people with obesity, and please, we insist from IASO, do not use people first language. Do not say obese or overweight. It's people with obesity, of patient with obesity. We have to talk with respect about these patients because they are sick, they have a disease. And now we have a lot of people with a severe disease. It's like, let's say, like liver cirrhosis. Once you got into cirrhosis, it's very difficult to go back to a healthy liver only with lifestyle. So that's why I'm giving 4, being generous.
Okay, thank you. So our marking is getting more severe. Cyril.
Yeah, thank you. I think I will be in the middle, so 5 out of 10. I agree with both of you. I think there's very positive signal. As you said, the best buy from WHO are moving and start to be implemented in the EU. There's a clear awareness of what we should do. I think what we're struggling with is actually action and implementation on many aspects. So there's still lots of improvement in that aspect. And to me, my biggest worry is that the liver is currently the blind spot. We don't see really the liver health in the agenda, whereas we know that actually it's a key organ trafficking within glucose metabolism, lipid metabolism, energy, and it's directly linked with all this non-communicable disease. It's a major driver of cardiovascular disease as well. And as we said, there's also the risk of severe liver disease that it's clearly linked to all these metabolic diseases such as type 2 diabetes, obesity, and so on. So to me, there's still room for improvement, but I'm very optimistic that we're going to make it, and we really wish at EASL that the liver would be really recognized as important, and liver health particularly should be really taken into consideration.
Thank you. Gamal.
Well, for non-communicable diseases in general, I give less than 50%. But for the liver, much lower, because there is a lot to be done for awareness and from patient perspectives and general population. There is a lot to be done from the policy makers, from the health authorities, and from the scientific societies to reach the real patients, and also the people who are not aware how obesity could affect their healthy liver. It's not healthy. Mm-hmm. So less than 4.
Let me come to you. The question I've given to all the panels is to mark out of 10 current EU prevention levels efforts when it comes to particularly to obesity and metabolic diseases?
Does the question refer to EU, what EU is doing as European Union as a whole, or also includes member states? Because because we tend to mix up what EU can do and what member states can do, and then usually EU is blamed for everything, even though in health EU has pretty limited competences to act. So how public health programs will be organized, what will be funded and prioritized on the national level is all decided by the member states. EU can support, provide some financial incentives, and there is some regulation where EU can do something about that. So if we focus on what EU can do within its competence, I would also give it 4 or 5, something like that. Because there are some things that we can do that where we actually have a competence. So it's very limited areas, but we haven't done anything about that. I'm primarily referring to the front of pack nutritional labeling. So that's the big topic. We've been discussing this for years about providing clear, understandable information to patients, to people, to all people, not just patients, but to everybody about what they are consuming. But we've been waiting for years for the Commission to come up with a concrete proposal. So definitely, in those areas where we actually have the power to do, we are not really doing anything, and this is why 4 to 5, probably closer to 4, unfortunately. So definitely in regulation, things that we know that we have to do, that we've been waiting for years to do it. I have to say, I put the blame primarily on the Commission, because the Commission is the one who proposed this legislation, not the Parliament. We've been speaking about nutritional labeling for years, but we don't have the power to propose this legislation, to put it in procedure. So that's definitely one problem. And the other problem in general, that what we are seeing now with the next 7-year EU budget, where health is definitely not represented well enough. So definitely EU is not. I would say it has not achieved a lot as the European Union as a whole. But the problem is that we don't see the trend going in the right direction. Actually, we see the opposite. We're seeing that health is becoming less important on the European Union level than it was 3 or 4 years ago. When we had the pandemic, it was beating cancer plan, the idea of European Health Union. So these things that were discussed then are now kind of in the margin. And this is something that we need to change.
Thank you. I'm interested that several of your interventions reflected the fact that over time our understanding of obesity and metabolic diseases has moved beyond this sort of basic information that people should eat less and move more and it's all their fault, to understanding this is a chronic disease that is affected by an environment around them that includes the food environment, urbanization, mobilization. So Kremlin, I wonder if you could help us to understand how the WHO's best buys look at the individual within a broader societal perspective, and how much is that affected by the fact that we've moved our mind shift forwards a little bit, so we are looking no longer just at the individual choices that somebody makes in the supermarket, but understanding the whole environment around them.
Thank you. I think we say one of the main barriers for lack of progress is still we have this narrative, this is individual responsibility. We have really not shifted away. Maybe it has shifted in the minds of the people who are in this room, but in general still we think, okay, let's educate the public, let's empower the people to make right choices. And that shift, that is still there. So I wouldn't say we have really moved on from that. But understanding the evidence about the impact of policies that change the environment is getting stronger and stronger. In WHO best buys, the most cost-effective interventions, we look at what are those policies that will give $1 investment, give $14 back. Right? Return on investment is very high, and that's highest for nutrition-related policies, more than for alcohol and tobacco, because it affects nearly 2/3 of the population. And those policies are simple policies that we already heard about: the front of pack labeling, marketing restriction of unhealthy foods to children, taxation of sugar-sweetened beverages, food procurement policies that also include public awareness, but together with other policies, not on its own. And also food reformulation, mandatory reformulation on sugar and salt in processed food, things like that. This is not new. We had that in 2010. It's 15 years we have not implemented them. Or when we implemented them, we gave voluntary approaches, and they have not been successful. That's why the obesity levels are still going up. But the silver lining is, like Norway, 2 weeks ago had a new law on marketing restriction of unhealthy foods to children, because for many years they had the voluntary approach, they had good data to monitor, and show that it's not actually protecting children. So they were able to show voluntary approach do not work, we need to move to legislation and have policies to protect children. Now, some countries are still talking about introducing voluntary approaches. Now, we should not spend another 10 years to learn that again, because we can learn it from Norway and Portugal who have the legislation. So I think there is common understanding that if we want to make a difference, we need mandatory policies that change the nutrition environment.
Thank you. I'd like to move on a little bit to understand more about the liver. That's sort of quite not very well known organ inside our body, which you've mentioned, is critical. It processes glucose and lipids. It's absolutely integral to the sort of caretaking role that the body does. But we don't understand enough about it. Now, as I described in my framing, the SLD, the new framing, people might have heard before of fatty liver disease or MASH or NAFLD. Just unpick all of this, because I think in popular culture, I think we understand that drinking alcohol heavily leads to cirrhosis, and that's a problem for the liver. It's less well understood that there is a connection to nutrition, and that also you can look externally reasonable, but there can be hidden danger happening around the liver. So can you just help us to understand this different terminology and why we need to get to grips with it?
Yeah,
Cyrielle, go
sure.
first.
Thank you for bringing that up. I think it's really important. I do agree with you. There's still a lack of awareness in the general population on what is exactly steatotic liver disease. And it's also true that even among our colleagues and MD, there may be lack of awareness of the different stages and differences of the disease. So it's really important that we keep on, bring awareness. And you mentioned that there was a new nomenclature since 2023. And the idea is bringing all this disease with steatotic liver disease in the one big umbrella. And then we have subcategories, right? And you talked about the previous name. We used to name it non-alcoholic fatty liver disease. Now it's called steatotic associated metabolic dysfunction, steatotic associated liver disease. And it's really putting in front the fact that it's a metabolic disease linked to metabolic risk factors such as diabetes, dyslipidemia, overweight, and not only obesity, but any patient with overweight is also a concern, and also potentially hypertension. So the whole spectrum is there, and you have just need to have fatty liver that you can diagnose very easily with an ultrasound or also potentially blood test. So, and then we have also the possibility to include now mixed etiology, taking into account the fact that there are some patients that have excessive amount of alcohol consumption, which falls into this umbrella of the steatotic liver disease called the MET-ALD. And this is also very helpful because, as we said, there's a lot of connection in terms of nutrition and its healthy lifestyle, which would include also taking care about excessive consumption of alcohol, because it's a cofactor that actually will be one of the drivers along and in synergistic ways with the metabolic risk factors that could harm the liver. So it's actually very important.
Thank you. Gamal, perhaps you could help us to understand, what kind of incidence we have. How many people in Europe are affected by this, and then how many of them know that they are affected by this, that they are living with this condition?
Many patients are obese, and they come to the clinics asking for, we have a fatty liver in ultrasound. We want to be sure that we are healthy. These people are many, but there is a point of caution here. Not all obese are liver patients. Many obese patients have no steatosis, no inflammation, so no risk of liver disease. So here is the awareness of the general practitioners and specialists to calm down the patients and or the people coming for advice. So to categorize them and to inform them, you are healthy, you have fat in the liver, but this does not affect the liver. Advice, just reduce weight. But those who are coming for fatty liver and the investigations showed that there is affection of the liver or start of inflammation and fibrosis, they should be referred to specialists. So the number is not low. There are many patients. As you said, 50% in Europe are living with obesity, and in some areas in the world, in the Middle East, the number is 60%. So the number is huge. The point is how to educate patients and how to select those, go to the specialist, and how to calm down those who are coming and they are still healthy.
Thank you. And I'm going to invite us all to pick up on the points that Andrea made, which was to use an appropriate language when we talk about it, to say, you know, people with obesity, because it's a condition that people live with. Now, you've said that people with obesity, people with overweight, or even with diabetes, not all of them will have a problem with the liver, but sufficient numbers of them will and may not know about it, and they need specific care and careful follow-up. I wonder, Andrea, can I bring you in this, because I'd like to open up the question of stigma and equity. So let's, looking across Europe, what do we know about, you know, equity across Europe? Are some countries better than others? Are there some countries where it's completely invisible? When we look across Europe, are there black spots in terms of addressing this, or is it sort of generally the same?
Yeah, good question. And actually, I'd like to make a brief comment related to the first interventions. I'd like to explain this from the perspective of obesity, and maybe to explain why you see people with obesity that with healthy liver or other people with fatty liver. And then I will link with stigma, because actually obesity is not a weight kilograms based disease, it's an adipose tissue disease, which means excess and dysfunction of the body fat. And dysfunction of the body fat, you can see it even with BMIs of 25. Actually, IASO changed the framework of the diagnosis of obesity last year and was published in Nature Medicine, saying that people with BMI above 25 and the waist to height ratio, which means a big belly, let's say, of above 0.5, they actually have obesity. And we have to look actually at the functionality of this adipose tissue, which means if this adipose tissue has inflammation or fibrosis, these patients will have a more risk of metabolic complications. And one of the metabolic complications of obesity is the fatty liver. And if this adipose tissue is healthy, they will not have metabolic complication. They will have a large volume, but they will have only mechanical complications like knee osteoarthritis, for instance. So it's not so simple, and it's not everything around nutrition. Obesity actually defines a group of heterogeneous diseases, neuroendocrine diseases characterized by a disbalance between the regulation of the appetite and metabolism. And now we know that there are a lot of hormones involved in the regulation of the appetite. There are genes besides nutrition and environmental factors, so we can't put everybody in the same bag, and we can't go in circles around nutrition, because this. You see now the prevalence of obesity is keeps growing, so this is not the way to do it. And maybe there's a lack of communication between policy and science, because I think that we have to explain you all of this in order to make you understand that many plans or policy plans don't work, just will not work, because they are not science-based. They are, I don't know what based, but science-based they are not. And then this will link with stigma, and it's very, we are very happy to see that you changed the nomenclature for non-alcoholic fatty liver disease into metabolic fatty liver disease, because this was very stigmatizing. We try to change obesity into adipose-based chronic disease, because actually this is what it is. And yes, there is a lot of stigmatization, precisely because there is a lack of knowledge about the biology of obesity, and the healthcare providers, actually we are the first that are stigmatized. We keep telling people to eat less and move more, and people are feeling very frustrated, and they won't come back. even in the society, when you see a person with obesity eating a large portion of food, we stigmatize that person. But stop and think about that that person is actually lacking the hormones that have to inform the brain and tell the brain stop eating. They don't have these hormones, so they can't stop, okay? So yeah, there are black spots across Europe. There are countries that are more aware about obesity, about biology, about what we have to do. The problem is that even if the healthcare providers are more aware about it, obesity is not recognized as a chronic disease. If I'm not wrong, only Italy has fulfilled this goal this year, a couple of months ago. So as far as obesity is not recognized as a disease, there will still be stigmatization and a lot of black spots across Europe.
Thank you. Tomislav, I'm going to come to you now because we've had the hot potato sent to the policymakers to say that it's not necessarily science-based, some of our policies. We still don't have the proper recognition about, obesity and adipose dysfunction, and that this only one country so far has properly recognized and classified. Thank you. Two countries? Portugal as well. Okay, so Italy and Portugal, only two countries so far. Both countries that, of course, have recognized the huge issue with the next generation of children living with obesity. So the protective effect of the Mediterranean diet appears to be lost there, and they are particularly picking up on that. But policymakers haven't really grasped that point, that obesity is a chronic disease. It is not a failing of individual choices. It is a physiological situation. And if that hasn't happened, then we aren't going to get the policies in place that will address it. How would you respond?
Yeah, I cannot speak on behalf of all the policymakers. I can speak about I can speak about EU. Why EU is speaking about front of pack labeling, things like that, because it has actually the power to do something about that. EU does not have the power to decide what will be recognized as a chronic condition or not. So that's the main issue. EU does not have the power to decide what will be covered by health insurance, what kind of health treatments and things like that. So this is what I'm saying. So EU can act in those areas where actually it can act, and that's the easiest way. So to speak about marketing, about labeling. Now, the taxation on unhealthy foods, so that's one idea. So these are the areas where EU actually has the power to do something. On the other issues, unfortunately, it's more down to the member states about what public health priorities should be, etc. EU can provide some guidelines and recommendations. I agree. It's important that the whole thing is destigmatized, that it's not only about lifestyle, but that there are more deeper genetic factors or internal factors which are not just because of your personal preferences of what you eat, etc. But so that awareness needs to be raised. But in the end, if I speak on what we can do on the European level, here our possibilities are mostly focused on the rules on labeling, on marketing, on taxation. So this is something where we can do something concretely on the European level. But I agree in terms of raising visibility, in terms of getting rid of stigma. Definitely, EU could play a role there. We should have more discussions on that. This is something that should be reflected in the strategic documents as well. This is why now we are waiting for the cardiovascular plan, because things are pretty interconnected there. And I hope that we will see some improvement. But again, as I'm saying, as far as concrete measures go, EU has limited powers to act, and this is why it's acting in those areas of marketing and labeling that I mentioned.
Thank you. I wonder if we could perhaps talk about the GLP-1 and the sort of new treatments that have come out, because the question we asked right at the beginning is, can the EU turn the tide on NCDs, obesity and liver health? And one of the big changes in the last few years is we've finally got a treatment that is starting to show impact. You mentioned, Andrea, that it is a hormonal dysregulation linked to adipose tissue. And there are issues around equity because not everyone has access to them. There's a lot of co-pays where the patients pay themselves. Should we be saying the good news is coming over the horizon, we've finally got some treatments that will make a measurable impact on the numbers of people who are living with obesity or living with overweight, who are on that trend towards a problem with the liver? The good news is almost there. Is that where we are?
Yes, actually now we have available 2 drugs that we are calling them game changers. And actually these drugs are not coming from another planet. They are copies of the hormones that regulate the appetite and metabolism. They are copies of the incretin hormones that a healthy body is doing every time that we eat. Our small bowel is synthesizing these hormones that inform the brain that we are eating, so stop eating, and then process properly the nutrients. So these drugs are the analogs, are the copies of this, and that's why people with obesity, and this supports the idea that this is a biological disorder, because when we give them the hormones, it's like the substitution therapy, like we do in hypothyroidism or in type 1 diabetes. They respond because their body, their biology is restored. So they are really game changer. Their potency is very high. There are now a lot of new drugs under development in phase 3 clinical trials, which means in the next future they will be here. And they are combinations of 3-4 hormones that are involved in this biology. The problem is that since obesity is not recognized officially as a disease, these drugs do not have reimbursement. So people have to pay them from their pocket. But the reading of this is double, because people is paying for the treatment that is restoring the biology of a severe disease, is preventing or is improving the metabolic complications. Type 2 diabetes goes into remission, fatty liver also goes into remission, cardiovascular disease is prevented, so the health system is saving money twice. You know, because people is paying the treatment and we are removing other treatments. And actually, now the best drugs to treat the fatty liver are tirzepatide and semaglutide, which are the drugs for obesity.
Thank you. I'll bring Cyrielle in on this and then I'll come to you, Kremlin, to look at the WHO view. But Cyrielle.
Yeah, I just wanted to comment a little bit further on that. There's a really, as you said, multiple benefits of these effective drugs that are now approved for obesity. 2 things. We need to recognize that obesity, as you said, is a chronic disease. And we know also that this then should be chronic long-term therapies. When people start on the therapies and then after a couple of months or year of stop, all the studies shows that the weight comes back and obesity comes back. So it's really also something very important to understand. It is a disease, it is a chronic disease, and it's the same for steatotic liver disease. So we really need also to change the policy to make sure that the patient gets the right treatment but can sustain it and have it for the long run, as it is for hypertension, as it is for dyslipidemia or the treatment of diabetes. The good thing is also that not only it improves steatosis, but we have very exciting data that shows that it's improved inflammation and fibrosis. And the studies are still ongoing to demonstrate that it can reduce also hard liver and outcomes. So these are probably going to be also a game changer for the liver field in the future. When the semaglutide has been recently approved in the indication of MASH by the FDA in the US, so we are probably going to have also good news in Europe in the future. So I think these points are very important. And regarding the reimbursement and coverage, this is key. We know that obesity and also steatotic liver disease are mostly affecting patients with low socioeconomic income. And then finally, the one that needs the most, the drug the most, are the ones that cannot afford it. So it creates a massive inequity in health, which is really not what we are fighting for as a medical doctor. We would like to treat everyone in a fair and equitable and sustainable way.
Thank you. Kremlin.
Yeah, so we'll try to pick on a few points here. I think you mentioned about having the new treatment, the horizon, and the opportunities that present, but also the cost on the individuals in affording that or who cannot afford that. I want to take a step back and say it's not only the cost on the individual, it's also the cost on the health system. So we have looked at for NCD mortality. We had a target to reduce the premature deaths by 25% by 2025, by 1/3 by 2030. There are 10 countries in Europe who already hit that target, baseline 2010, who reduced NCD mortality by 2025. WHO published that report for the UN high-level meeting. What are the lessons we can learn from those countries? One of them is Belgium. The lesson is, when we look at how they reduce mortality, both preventable mortality and treatable mortality on the two axes, these countries in the same line reduce both preventable mortality and treatable mortality. That's how they avoided deaths. So for any strategy, diabetes, cardiovascular disease, the prevention and treatment go hand in hand. We don't have any country as an outlier who only achieved this by treatment and had very high preventable mortality, or other way around, who only reduced mortality just by prevention without treatment. So that's the reality today. Second point is, we are talking about the cost of these new drugs. WHO has the guidelines, and everyone, it is a disease, we have ICD code, we have the guideline. Everyone who deserves, according to the guidelines, should get the drugs. That's not the question. Let's think about ineffective drugs, such as the statins and hypertension drugs. We have this for years. They are off patent. They are cheap. But in Europe, only 1/3 of the people have hypertension, whereas obesity 2/3. Out of those population, 1/3 don't know they have hypertension. And those 1/3 who know they have hypertension are not, 1/3 are not on treatment. And out of those who are on treatment, 1/3 are not on control. That means even for the cheapest medication, we cannot really meet the patient demand and meet that. That is the capacity of the health system. And we don't have enough doctors and nurses. And in the aging and with the NCD trend going up, we will never have enough doctors and nurses in the next 10 years unless you prevent the number of patients who require these services. So I worry that everybody thinks now we have a drug, let's not do the hard political work of prevention because the drug is the answer and we drop the agenda on prevention. I think we really need to make sure for those patients who need the services, our health system should have the capacity to take care of them. And to take care of them, we need to reduce the number of patients who are entering there. So I think prevention should go hand in hand. Thank you.
Thank you. I've started to look at the list of questions, and we've got a long list of questions. So I think I'll go to the Q&A early because I think there's some great suggestions coming in. So this one is perhaps, we've got a question about employers. Employers are heavily impacted by chronic disease, which increases absenteeism. What's the role that employers have to promote early detection and prevention? And I say that because, we need to discuss a little bit, how do you know that you might have one of these things? I know if you go to your GP, they can take your blood pressure. It's something you can do at home. A stethoscope checks your heart. How do you get access to the liver? So maybe we can talk a little bit about that. And then, is there a role for employers, workplace health? Is that one way we sort of reach people? Cyril, I'm looking at you perhaps to answer this first.
An excellent question. Regarding the question, how do we know and how do we assess the liver? We have made tremendous progress among the last 10 years, and we know that there is many marker or biomarker of liver health that we can use. The first test that is now widely recommended is to do a FIB-4 score, which is just a combination of age and the platelet counts, AST and ALT, so the liver enzyme, and put that in a formula that it's cheap because it's free of cost. It just costs the lab test, gives you an indicator, a number of your risk of having not steatotic liver disease, but having severe form, and this is the most important. So if your score is below 1.3, you don't need to be, as we said, go to see an hepatologist or a liver specialist. But if the number is above 1.3, there's a risk. You should be aware that there's a risk and there's a follow-up. And the follow-up is to perform a second-line test, which is more accurate. It can be, usually it's a transient elastography, but there's also drug test that has been developed. So depending on this health system and setting and availability of these tests, we have no a range of tests. It can be the stiffness of the liver with transient elastography, which is an ultrasound-based method, or it can be patented blood tests that are a little bit more costly. So we need to, design the pathway and the screening strategy wisely. But you can have an answer, and you can know. We will really advocate also this one of know your number. You should know what is your liver stiffness measurement to make sure that your liver is on the healthy side, or if there's a worry.
Thank you. Gamal, let me bring you in on this. Is there a role for workplace health? Because already in some workplaces you will have guidelines around helping people to quit smoking. You've got workplace health where they might have interventions around alcohol. Should we be trying to do something in the workplace about helping people to know their number, get people talking about how stiff their liver is? Is that a space where we would engage with people of working age who are at risk?
At their work, at their place of work.
Yeah. Employers, what's the role for employers here in helping?
I think in countries where there is health insurance, employers can benefit from this by doing the simplest screening tests, as a simple blood test or even abdominal ultrasound, which is a very basic thing and can tell you is this liver fatty or not for further investigation. But awareness, again, could be a very important step, even at workplace, about the importance of having screening for the liver and other metabolic diseases.
Thank you. We've got a question here that is a nice challenge. We've got a question that says, could you each suggest one impactful policy change that could address SLD or obesity at either national, European or global level? So lots of freedom there for you to choose, but what's the one policy change that could have an impact on these issues? So Kremlin, I'm going to start with you because you can look at all of these levels.
I think this is very clear on our report. If you read the WHO obesity report, it says there's no single intervention which can tackle obesity. A lot of politicians think I will solve obesity with my one policy, and they do it and the obesity levels goes up, then everybody else says you failed, your policy didn't reduce obesity. The lesson here is one policy cannot reduce obesity. But if I had to pick one policy, it's about conflict of interest. If you change your government policy to recognize conflict of interest and protect public health policy from the influence of conflict of interest, that's going to solve obesity.
Thank you. Tomislav, you've mentioned already the food labeling, the front of pack, etc. But what's the, and maybe perhaps you could also speak from national level, the country you know best. What's one policy change you'd like to see put in place that could have an impact?
No, I think on European level, definitely on labeling. That's the most direct thing that we can do on the European level. On the national level, I think, in addition to all the information and visibility that we already mentioned, definitely reimbursement of the new treatments. I think that's something that is decided by the member states. But definitely, I think that, as was already said, we have to combine both prevention and treatment. And here, on the level of prevention, EU can do a lot. But on the level of treatment here, definitely member states are the ones who have to step up. So I would say definitely to cover the newest available treatments on the national level, to reimburse them, that's crucial.
Thank you. Andrea?
I think that one thing that will mark a change is recognizing obesity as non-communicable disease, because this will generate a cascade of actions starting from mandatory national plans at member levels. And this means if obesity is an NCD, then the national plans are mandatory to be implemented, But now it's just at the philosophical level because there is no official recognition.
I'm the last. So I think it's a very difficult question, and I agree it should be a multiple, level action. But What I think what is very important also is targeting the young generation and the children, promoting a healthy lifestyle. I'm talking about nutritional behavior, including food and physical activity, because we didn't touch upon physical activity, but it is also key in the prevention of metabolic disease, obesity, and steatotic liver disease as well. So I think we should really also make sure that the young generation gets the awareness of what is a healthy lifestyle that they can then sustain for a lifelong period, and this is really important. We're talking about excessive sugared, sweetened beverages and so on. And for the teenager, I think alcohol consumption also is an issue that we need to address and make sure that they have the knowledge and awareness of what's the harm of alcohol consumption. So there's a whole panel of things we can do targeting the young generation from young children and adolescents to improve and prevent these diseases.
Yes.
One brief comment, because I agree that prevention and treatment should go together, but with the proper knowledge, because there are many types of obesities. Not all of them are preventable, and I will make the comparison with diabetes. Type 1 diabetes, you can't prevent it. There are patients with type 1 obesity, let's say, they lack the hormones. Type 2 diabetes is preventable. The type of obesity which is more prevalent, which is of course the one that comes from lifestyle, can be prevented, but we have to work together and be able to phenotype and differentiate what is preventable and what is not, and what needs treatment lifelong and which patient don't.
Okay, thank you. Let me look through a few more of these questions. We've got one that's very specific, that Andrea, that's coming to you, because it's about the EASO algorithm, which supports, and you just mentioned it, the concept of phenotyping that would mean we could get more appropriate care for people with obesity, particularly those who haven't been caught early enough through other mechanisms, who would then be on a pathway towards SLD. So perhaps you could just talk a little bit more about this. First of all, explain to everyone what phenotyping is, and then why that's so important.
Yeah, phenotyping means giving the proper name of the type of obesity that the patient has, which is genetic, which is due to lack of hormones, which is, there are a lot. Okay, so this is phenotyping, properly diagnosing the type of obesity. Regarding the EASO algorithm, which I had the honor to co-coordinate together with Barbara McGowan, my colleague from EASO, what we wanted to transmit, and this is the first treatment algorithm that says that when we treat obesity, we have to, not always the goal of treating obesity is losing kilograms, is losing weight. This is a mistake. We have to know what we want to treat and to settle a personalized goal. For instance, in a patient with cardiovascular disease that had a myocardial infarction, the goal to treat is to prevent a new event. And this can be, you can achieve this regardless of the number of the kilograms that you lose. And another reading of this is, when we treat obesity, our goal should be to reduce the body fat and to increase the body muscle. So if you lose 10 kilograms of fat, and you earn 8 kilograms of muscle, in the end, you lost 2 kilograms. You would say, what a disaster, but actually it's a very good result. That's what our algorithm is trying to say. When a person has no complications related to obesity, the goal to treat is to prevent that the fat mass disease will develop complications in non-adipose organs, which means, yes, in these patients in particular, we want them to lose weight, because we know that the drugs now, the weight that is lost, more than 75% is fat. So this is our goal. If the patient had already complications related to obesity, the goal to treat is to restore the dysfunction in this organ, regardless of the body weight, and then your secondary goal can be the body weight. That's why the drugs are listed in according to their impact on the specific complication.
Thank you. Cyril, I wonder if you can help us to just unpack a little bit more. From your perspective, you specialise in the liver. What do you wish we all knew about the liver? Because it is a sort of an undiscovered organ. It's not talked about much. What is it that you, and we've spoken a little bit about general education and awareness and understanding, what is it that you wish we all knew about our livers?
Well, I wish you all knew that liver health is important, and that actually liver health or having an impaired liver health will impact not only your liver, but it's also a driver of cardiovascular disease, for example, or many other aspects. So I think what I wish for all the audience and all of us to remember is that liver health is important. It's directly linked to key clinical outcome, and it's really important that we take care of it. So that's really the key message here, and with that it comes with early detection, right? Also, if we can all be more engaged in promoting the screening for advanced liver diseases to make sure that the patient that needs special care gets actually to see a hepatologist or liver specialist, and that we can treat them or intervene early in order to indeed prevent the development to severe liver disease, cirrhosis, and also reduce the risk of liver cancer, that would be wonderful.
Okay. Thank you. And you've mentioned liver cancer because that is one of the areas that is a growing challenge. We have an approach at EU level. We have the Beating Cancer Plan and others, but it's, is liver cancer amongst the top 3 or 4 that they're targeting? We've got screening out there for 6 organs. Is liver included in that? To what extent? We've heard in the conversations around diabetes and obesity that the liver is insufficiently visible in those conversations. Let me ask you that same question about cancer. Have we sort of really understood the role that plays?
2 things. Yes, liver and also steatotic liver disease is a risk factor for liver cancer, but not only liver cancer. There's also non-hepatic cancer that are increased in the presence of steatotic liver disease, and as well as obesity. So we need to remember that it's not only the liver, it's the whole risk of cancer. We, as clinicians, have very clear guidance. Once we have a patient that we identify with cirrhosis, for example, there are clear guidance that needs to be implemented. It's actually covered to do screening every 6 months. The only issue, and I can tell you from my own perspective in my clinics, as you said, I'm a diabetologist dealing with patients with diabetes and obesity. We have implemented since, I think, 5 years now, a systematic screening of our patients, checking for liver health. And I have regularly patients that I diagnose or discover advanced liver disease, such as cirrhosis, compensated, completely asymptomatic. I wouldn't thought that the patient would have cirrhosis, and the patient didn't know. And this is a game changer as well, because the moment we identify this early, we can intervene and we can engage the patient in the screening. And this is also very important.
I fully agree, actually. I at the obesity clinic at my site, we are performing the FibroScan for all the patients that come as first visit with obesity, and we find some with advanced, with severe liver disease. And they didn't know, and the blood test is normal.
Yeah. Okay. And unfortunately, our experience are very, university, hospitals driven. Yeah. And what is lacking is the wide implementation in every, healthcare system across the whole EU. So that's what we should achieve.
Thank you, Kremlin. I saw you nodding when they were talking about that yes, if you've got to the point, you've got through the doors of a hospital clinic, you're actually in treatment for another condition, and it's discovered you have a liver disease, great, but that's not going to affect the sort of 40% or more of people who are walking around with their livers affected who may not know it.
I think those patients are lucky to have that kind of services. I was just thinking, the patients who come to your clinic are the lucky patients in Europe, right? And that's not the average patients in the population. I'm just going back to your point about that. Can doctors talk to them before they develop the disease about their diet, physical activity, so they don't need to be screened and walk through those hospital doors? So I'm not sure in Brussels, but in many countries, if you ask the patients, have you visited your primary healthcare worker in the last 5 years for any reason? And how many times did your primary healthcare worker, it could be a doctor, nurse, a dietitian, initiated a discussion with you about your diet, physical activity, tobacco, alcohol, how many times on their own initiate the discussion? 80% of the times people say no. My primary healthcare person never started a conversation without I am asking. And then we surveyed 8,000 doctors, nurses, and dietitians in Europe, asking, do you initiate a dialogue, and why? If not, why? Two things came up. One is lack of time. Second thing is they thought patient might think I'm judging them or I'm wasting their time, right? If they thought if I start the diet, they think I'm judging them on their weight, right? And then it might disrupt my relationship with the patient. So the situation is that these are the risk factors which affects 85% of deaths, 90% of DALIs. Right? These are the things that cause 80% of deaths, but we don't talk to 80% of the patients about these risk factors. So before we get to screening with a lot of expensive machines, we want a health system which talk to patients about these risk factors, health system which has the capacity to do that. So I think it's very important we talk about how to integrate it primary healthcare system, how to create space, going back to that, reducing the burden. Yeah.
And of course, the key issue there around stigma,
Yeah.
which is that there is so much sort of stigma and discrimination that exists that it makes it a controversial, difficult issue to be discussed between a patient and their healthcare provider. So, and it shouldn't be. It should be a natural part of conversation about health.
I just have one comment. Every study has shown that the screening strategy, when they are implemented, are cost effective.
Yeah.
So that's really important, and the tools are not so expensive. The first line tools are pretty accessible. I agree the second line, when you have, as I told you, is two-step, right? First doing a blood-based biomarker like Fibro, this is quite inexpensive. It's the second step, but this, if it's well performed, it's really should target a minimum number of patients.
The 5-4 can be implemented in primary care, in the blood test screening, for instance, as a first step.
There are many screening programs for cancer also which are cost effective on evidence. The most important thing is to see, once you roll it out, whether you reduce the disease burden in the population. So that also need to be taken by politicians when they make the decisions. So that's why some cost-effective screening programs don't make it to the national policy. That's a difficult choice with limited resources.
And we need more program and studies for that as well. So.
Okay, well, you're bringing me very nicely to sort of the last 10 minutes or so of our conversation, where I want us to start thinking, okay, what can we do about this? And what can we expect reasonably to be addressed at European level that could support policy action at national level? So let's look at areas around screening, around information, data collection, the EHDS. Let's look at efforts to increase our scientific knowledge, research policies. Let's look at issues that would look at stigma. We've got a question here about the link to mental health. So let's spend our last sort of bit of time together to say, what do we want to see happen from a policy perspective, and where would we like EU leadership to be? Because the question at the beginning was, can the EU turn the tide? So let me ask us. Thomas, I'm going to start by you. Where would you like to see some policy opportunities? You might want to talk about the EHDS, for example. We suddenly will have huge amounts of data that will allow us to maybe see new patterns, etc. We've got new legislation coming. Where do you see the policy opportunities?
Yeah, maybe it would be better for the experts to first say their input so that we can respond to that. But okay, so first we have to cover everything. So prevention, early detection, treatment. So we have to cover the whole thing. When we speak about prevention, we already talked a lot about that. So everything that we can do on European level in terms of taxation of unhealthy food, in terms of labeling, in terms of marketing. So all of these things, definitely EU can play a big role there. When you speak about early detection, screening is very important. I agree. This is something that EU can support, can fund also at least partly through the health budget. The problem is that we don't have a health budget in the EU anymore, which is a big problem now, and we have to fight to have at least part of the funding ring-fenced. And the main problem here is that, so in the Commission proposal for the next 7-year budget, it's not ring-fenced anymore. It's not a separate program. It is partly in competitiveness and partly in the resilience, so about resilience for preparedness for crisis, pandemics, etc. So the public health programs like screening, for instance, raising visibility, awareness, etc., actually fall between the cracks because they're not, strictly speaking, neither about competitiveness and neither nor about resilience in that classical sense. So this is why we'll have to fight very strongly to maintain and protect this budget for public health, and then we can speak about supporting national policies in terms of screening, in terms of raising awareness, physical activity, etc. Of course, evidence-based. On treatment, so reimbursement is national competence. This is why I said that's the national authorities to decide. But what we can do is to make procedures for authorization of new medicines to go faster. This is what we are doing with the reform of the pharmaceutical package. So we want to shorten the timelines for EMA to make decisions on new medicines. We want to make the whole procedure be easier and simple. What we are pushing very strongly for is that all medicines are available, put on all national markets at the same time. So not reimbursed, that's national decision, but at least be put on the market of member states. This is what we are proposing. The European Parliament is proposing and fighting very strongly to impose an obligation on the pharmaceutical companies that when a request is made for a new medicine to be made available, that they have to make it available within 1 year. So member state A says we want this new medicine to be available on our market, they have to provide it within 1 year. So in that way, if all the medicines are available in all the national markets of all the member states within 1 year, definitely then we can also use this to put pressure on the member states as well to actually reimburse these treatments as well. On the EHDS is something that can really be a game changer. So what we are doing is we are making health data like a public good that can be used for public interest. So that will be cataloged, systematized, and structured, and everybody who wants to do research on that or make policy studies, etc., will be able to access this data from all other member states. But it's also important that this is prepared in the right way. We have 4 to 5 years to do it. We have to prepare healthcare professionals. We have to prepare researchers, patients to actually trust the system, to be ready to feed the data into the system. Because if you don't prepare them, if you don't explain them the benefits of that, then we'll have a situation that people will be afraid that they'll be asking questions here. But what if somebody misuses my data? And people will not be willing to share their data and make their data available for the system. So if we want to have this enough data that is representative and unbiased, we really have to explain to the patients the benefits and also employ all the safeguards that this data cannot be hacked, misused, stolen or whatever. So but EHDS definitely has a big potential there. And also in research, EU has the Horizon program, which is the biggest, obviously, the big program for research in the EU, primarily for fundamental research, which we need. And here we also want to make healthcare as even a bigger priority than it was in the previous mandate, and then hopefully also there will be more funding available from EU level for basic research into areas related to liver health and NCDs as well. So EU, as I said, cannot do everything, but it can do a lot. What is important is to raise the visibility of the issue, because as you said many times, this is not such a popular topic in the Brussels bubble. So not a thing that is talked about that often in the same amount as mental health, as cancer, etc. So this is why we have to really push to raise awareness on this. The problem is that here, all of these measures that we mentioned, it takes pretty long time to get actual big results, And that's something that most politicians don't care about. They only look at short-term gains, something that they can sell to the public, to the media, for good PR, for a tweet or Instagram publication or whatever. So this is why we also need to put more pressure on all of the institutions and the other politicians to actually look at long-term outcomes and not just short-term political gains.
Thank you. Kremlin.
So if we want to turn that tide, that means we need to do something differently, because at the moment this burden of these diseases are going up. So we heard from our clinicians how they are doing their practice based on the evidence, based on the latest evidence. So we want to see whether our policies are based on the best evidence we have. My understanding is if we look at our current trends, Europe spent a lot of money from taxpayers' money to do research, to generate evidence. Have we given the benefit of this research to our population? So we need to ask that question. we generate best evidence about the benefits of breastfeeding. We are the lowest exclusive breastfeeding in the world, lowest level of exclusive breastfeeding. Our female smoking will be highest by 2030 in the world, highest in the EU by 2030 in the world. Our alcohol consumption, out of the top 10 countries, 7 are in the EU. So my conclusion is we have not really given the benefit of this research through policies to the public. And then we need to ask the question why we have not been able to give it. And that's a conversation all of us should look at without blaming each other, that who has a role in it. If this affects 85% of the people, it's going to affect all of us, our families. So we need to look back and see why have we not been able to translate this evidence into real policy to impact people. Like you mentioned, the food labeling, we know it works. We have not been able to implement it. We all might have different opinions. We could go on blaming each other, but we are not being able to do that.
You mentioned conflict of interest
Yeah.
and lobbying and interest groups. So I think the answer on that particular question lies there somewhere. Probably.
So I think that's a good thing to look at. So maybe one thing we could do is really look at how we make our policies, how can we protect them based on evidence, and how can we make sure those evidence can come through without and protect them from conflict of interest. If we really want to turn the tide, we need to protect them from commercial interests. I'll quote, because we're in Belgium, the minister said, we need to call spade is a spade. He said, I see a pattern that any policy that that may be seen as negative for the industry does not get implemented. And he said, we really need to address that, Minister Van Vankerbroucke. Finally, there is also mention that EU is now focusing on competitiveness. Any policy that may, marketing restrictions, labeling, may seem as anti-competitiveness. But based on what you ask about employers, we need a healthy population to contribute to the productivity, to contribute to the workplace, to be competitive region. I don't know why we have not really, why we see this as clashing policies. I think having good preventive policies to have a good healthier population will contribute for EU to be competitive. We need to advocate for that.
If I can just add shortly to that, that's the problem, because health spending is seen as a cost. And not a lot of people are aware of the fact that you have 14 euros for investment of €1. Yeah. So that's one of the reasons. And also what I said, the gains in productivity are not clearly directly visible. It's not something that you can, in the short term, sell to the media and to the public. And now, since now politics is all about short term, so from one twin to the other, so that's the major issue. So not a lot of policymakers, politicians is interested into things which actually provide some long-term effects and which are not visible, tomorrow.
Right, we've got about 3 minutes left, so that leaves you 1 minute each, the remaining members of our panel. If I go back to the beginning where I asked you to sort of give marks out of 10, let me ask you to think, what would convince you to move your mark up a little bit? What are you looking for as action?
4 words. Speak less and act more. And this will convince me to go from 4 to 5.
Tough marks there. Okay, I think that's very reasonable. Cyrielle.
I love it. So I would just maybe specify.
We
are women of action, I guess.
Okay.
Speak less, act specifically by putting liver health in the agenda of the non-communicable disease policy. Prioritize prevention, and as I mentioned, targeting also the young generation. 3, promote and help us work in an holistic way, because we are mostly working in the health science in silos, whereas what we are discussing is that we have patients with multiple comorbidities. One of the major drivers is overweight or obesity, and then there's a myriad of metabolic complications and cardiovascular complications and that are linked to this. And if we can promote systems where we can embed that in the clinical care, where we can do actually prevention and we can do screening and early detection while we are taking care of all the metabolic diseases, that would be the dream.
Thank you.
I think prevention is the key, and at a national level, if a national campaign for awareness at school children, targeting school children, the new generations, I think this will impact the whole situation in the future. Parallel to it could be a campaign, general campaign for the public to be aware of the whole situation of the complications of obesity, overweight, that it affects all the systems of the body, the overall health. And parallel to it, the GPs are very important. The first doctor see the patients is very important to be very well educated about the whole situation. I think these three parallel things could be measurable in the future, making an impact. So 3 will be 4.
You moved to 4. Well, thank you to the members of the panel for helping us to understand where you currently see the the delivery of policy options to prevent chronic diseases, and within that the metabolic conditions that so affect the liver. And you've also highlighted for us where you would like to see action in order to increase the marks that you could give. And let me just summarize by saying it's clear that we don't know enough about the liver. It is a hidden organ that is not yet enough in public awareness for the populations. It's not clearly in the sort of general conversations that healthcare professionals are having with their patients as they see them. It's not part of the general health checks that are done, and that should be done. So that's a population communication awareness. We were challenged by Kremlin to say, you know what, we actually know we've got the best buys, and we are insufficiently delivering and translating the evidence base that we have into real policies, partly because we have shied away from addressing the conflicts of interest, that the commercial determinants of health, they are, very powerful, and we see them as part of competitiveness of Europe, and we haven't actually calculated in the impact on individuals, because far too much of this is still put on the shoulders of individuals as what they should do differently rather than, how our society lives. So the changes that we need to see are multifactorial. They'll require multidisciplinary action. Thomas Saff, you've highlighted for us, within the mandate that exists at EU level, there is much more that could be done across whether it's data, it's the fast tracking of medicines and making sure that we use that effectively. It's bringing all of our policy to bear, particularly around food labeling and others. So if I can sort of try and take the average of the marks, I think nobody was higher than 6, and we were as low as 4. So if we could say that our goal would be in the next 5 years to get to, say, 7.5, this would already make a huge difference, because we've heard from Kremlin the trajectories in Europe around a number of different, health-related issues like smoking or alcohol use or food are very poor. And we need to do something about it. So thank you, panelists, for opening. I hope you've learned something. You've learned a little bit more about it. For those of you who are watching online, I hope you're going to go away and you're going to find out more about the liver, where it sits in your body, what it feels like. You're going to start thinking about what are your numbers for a stiff liver. That's what we should all be thinking about. For those of you who are here, we have a little treat for you, because we actually have a FibroScan machine. You can test your liver, and if you don't already know it, we've got a machine here you'll be able to test. So can we say a warm thank you to our panel for illuminating our lunchtime? So I'm going to close this, and goodbye to our online audience. And for those who are here, please scan your liver. Thank you and goodbye from Brussels.
Thank you very much.